Hello, I am your host, Arshad Khanani. In this episode, I'm joined by Dr. Christina Weng, Professor of Ophthalmology and Fellowship Program Director at the Baylor College of Medicine. Hi, Christina.
Hi, Arshad. Always fun to be with you.
It's great to have you. And in this episode, we'll discuss the current treatment paradigm for diabetic retinopathy, including management strategies that can improve outcomes. But before we get started, Christina, in this podcast, we ask several questions, same questions to all the faculty member before we dive into our discussion. So first, tell us, how did you end up being a vitreoretinal surgeon?
Well, Arshad, the retina always fascinated me as a resident, and it's not only so beautiful to look at, but I found it to be a really good and fun kind of challenging. And like many, I love the cool surgery we get to do and the therapeutic advances our field has made. But you want to know something that not a lot of people know? I was actually really close to pursuing oculoplastics when I was in training. So it's crazy to think about because I can't imagine being happier doing anything but retina. So life has a funny way of working out.
Well, so one thing you don't know either, that I actually did a rotation at Baylor in oculoplastics too, because I also thought about it. So we're lucky to have so many subspecialties in ophthalmology that are so exciting. So tell us a little bit about yourself. What's your favorite hobby?
This probably doesn't hold true right now because, as you know, it's about 105 degrees every day in the Houston summer. But I really enjoy running. A lot of people find it very boring because it's repetitive, it's really monotonous, but it's actually those things that sort of balance me out and bring me peace of mind after the craziness of a long day. So I like doing that, and I can't wait for cooler weather so that I can get out a little bit earlier in the day.
No, it's always fun to run. Have you done any marathons?
Not any marathons recently. I have done half marathons, but again, not in the recent past. So hopefully we'll get back to those distances sometime soon. It's just all about balancing that with these long days at work.
Lately, we're all being so busy with so many innovations, the trials, the meetings, and you also train fellows, and you're in an academic environment. So I'm sure you do a lot more than just clinic. So one last question before we move on to the topic at hand. What's your favorite vacation spot?
Favorite vacation spot? I would have to say Santorini, Greece, which is a place I visited a few years ago. Have you been before, Arshad?
No, that's one of the places I've not been to, but plan to go.
I'll put it on the list. It's honestly one of the most beautiful places. It's great food, warm people, spectacular sunsets. Highly recommend.
Oh, that sounds great. I'm all about beaches and sunsets, so this is great. Okay, Christina, let's dive into the topic at hand. It's so great to have you here. Tell us a little bit about you. Practice in a very busy hospital and clinic. You have a lot of diabetics that you are treating, and how are you treating your diabetic patients with diabetic retinopathy? And this is without DME initially. So tell us, somebody shows up with NPDR versus PDR. How are you treating these patients?
Thanks for this topic. I'm passionate about the diabetic retinopathy in general because I see so much of it. I know you've spent time in Houston too, Arshad. You remember how severe the pathology is here. So it is something that's near and dear to my heart. And I think when we're talking about treating diabetic retinopathy in 2023, it's important to divide it into two major categories. Really, we're talking about high risk PDR, and we're talking about NPDR in the absence of diabetic macular edema. Now, for high risk PDR, we really have three options at this point that are effective. We have anti-VEGF agents to choose from, pan-retinal photocoagulation, laser, as well as surgery. And depending on how the patient presents, you might elect to use any one of those or even a combination. Now, for NPDR, without DME specifically, it's a little bit less clear. This is an area we're actively learning about. And the options really at this time are either observation with medical management. Sometimes, rarely, we do pan-retinal photocoagulation, even for, let's say, severe NPDR patient. If their other eye, let's say, was lost to an advanced tractional retinal detachment, we do that for some of our county patients. And then, of course, I want to really focus in on anti-VEGF, which is really the most recent development in our field. And of course, when we're talking about NPDR in the presence of DME, we have several options here. We have ranibizumab, aflibercept, brolucizumab, faricimab, and even a biosimilar of ranibizumab called EQRN, which are all approved for use if DME is concurrently present. But in the absence of DME, making it even more interesting and complex to think about, we currently have 3 approved anti-VEGF agents specifically for diabetic retinopathy, and those are ranibizumab, aflibercept, and a ranibizumab biosimilar called ranibizumab EQRN. So per their labels, ranibizumab and its biosimilar are recommended to be administered monthly, and aflibercept should be dosed monthly for the first 5 doses and then every other month. But the truth is that it's pretty rare that retina specialists follow the label exactly. And this is especially true when it comes to treating DR because there really hasn't been established guidelines regarding treatment approaches in this area. And it can also differ depending on the severity level of the diabetic retinopathy that you're treating. But just to give you a couple examples from the major trials that we do have looking at NPDR treatment, in the Panorama study, which evaluated intravitreal aflibercept for the treatment of moderately severe to severe NPDR or DRSS scores between 47 and 53, patients in the aflibercept Q 8-week arm got 5 monthly doses, followed by Q 8-week dosing for the first year, and then were transitioned to PRN the second year, while the aflibercept Q 16-week arm got 3 monthly doses and 1 8-week interval dose, kind of like a quick treat and extend, if you will, followed by Q 16-week dosing for the remainder of the study. But it's important to note that the participants were evaluated monthly through week 16 and then every 8 weeks the rest of the time. So they were closely followed, Arshad, as you know, and rescue treatment could be given for the development of PDR, center involving DME, or at investigator discretion. And the treatment schedule I'll just briefly mention in another study for NPDR is called Protocol W, which was from the DRCR Retina Network. It differed a little bit in that the eyes randomized to aflibercept received injections at baseline, 1, 2, and 4 months, and then every 4 months through 2 years. And similarly, eyes could be rescued with aflibercept if they developed vision-threatening complications. But again, I think retina specialists, we're just notorious for putting our own spin on things. And I think we both have colleagues who treat more or less frequently than what was done in these trials. I mean, any thoughts to add? Are you actively treating these types of patients, and do you adopt a similar approach?
Yeah, so I think those are great comments and summary about the data we have available. I mean, like most of my colleagues, I am actually not treating moderate to severe NPDR with frequent injections in all patients because many of the patients don't want to have the treatment, especially if they have good visual acuity like 20/20. The treatment burden is obviously there, as well as, missed work and, cost and other things. So I do offer it because as physicians, we have to offer our patients the treatment that are available, but it's very difficult to convince somebody who is asymptomatic with just DR to get treatment. I think the motivated patients are the ones that had, as you said, PDR in the other eye. Then they may be convinced to just do anti-VEGF injections. So if you think about NPDR, we have about 8 million patients that are in the U.S. and that's the number quoted, in some of the studies, and majority of them are even less than 1% are being treated with anti-VEGF. So I think you're right. We need guidelines, but we also need longer acting agents because I think patients will be much more receptive if you had sustained delivery or longer delivery. So the TKIs are exciting that they can go 6 months or 12 months. We know the trials are ongoing. And then, of course, the Pavilion study showed remarkable superiority in patients who were treated with port delivery system compared to, observation with anti-VEGF injections as needed. So I think the field is still kind of evolving, in my opinion. Of course, if they have DME, then obviously that's an easy task. But I'm talking about just patients with DR, like you suggested. So what are your thoughts on having a surgical device like the port delivery system for treatment of DR? The data is remarkable in the Pavilion study in terms of two-step improvements. The safety data was actually very exciting also, that there were no cases of endophthalmitis. And remember, we had all the learnings from the neovascular AMD studies in terms of the surgical procedure. So any thoughts on the Pavilion trial before we move on to some other treatment options for DR?
Yeah, well, before even jumping into that, I just want to echo some really important points that you made, which is that It's great that we do have effective therapies, and the desire to want to treat earlier in the journey of diabetic retinopathy makes a lot of sense to me, right? I mean, we see patients who come in who've never had treatment with advanced tractional retinal detachments, and it's really just too late for a lot of them. Even if you do your best surgery for them, a lot of them will only improve so much in terms of visual acuity. So it seems like a great idea to want to treat earlier, but you're absolutely right that a lot of our major trials, while it has shown to be able to reverse the diabetic retinopathy and to prevent some of these vision threatening complications, the lack of a signal in terms of visual acuity improvement is definitely something to consider, especially in light of the treatment burden, which is still quite high in what we've seen from a lot of our programs so far in a lot of studies. And additionally, we've learned that interruptions in treatment can also lead to not only regression of effect, but in PDR can actually lead to a significant worsening in certain patients. So you're absolutely correct that I think having the longer term therapies that are being developed is such a critical move, because it'll tip this risk benefit ratio for us in a way that might allow us to turn to these therapies a little bit more often and actually treat earlier, which is something I think universally we do agree upon. It's just a matter of what that trade-off is. So I'm so glad you mentioned the phase 3 Pavilion trial, which of course is looking at a surgically implanted device called the port delivery system, which delivers a concentrated form of ranibizumab. And PDS is already approved, of course, for the treatment of wet AMD, although it was voluntarily recalled in the fall of 2022. But basically, it randomized patients with DRSS scores between 47 and 53 to port delivery system Q36 weeks, meaning that they had a mandated refill exchange at the approximately 9-month time point, and compared to how they compared them to patients who were not actively treated in the control arm. So supplemental treatment was given if patients developed certain complications like center involving DME, anterior segment neovascularization, or PDR. And just like you said, Arshad, essentially the study found that PDS was superior to the control arm in terms of the proportion of patients who achieved a 2 or greater step DRSS improvement from baseline at week 52. And the PDS arm was also found to have a lower rate of vision-threatening complications and also a lower rate of 2 or greater step DRSS worsening. Visual acuity was comparable between the arms, not unexpected. But getting to your question, Arshad, 100% of PDS patients did not receive supplemental therapy through week 52. Very impressive. I mean, imagine you have a surgically implanted device, you can go a whole year without having supplemental therapy, maybe even longer. So I do think that's really exciting. And again, it makes you reassess that risk benefit ratio slightly differently when you know a patient that doesn't have to come every other month or every 3 or 4 months. It makes a big difference for them.
No, I think that's a great summary. And I think the key is that we need to discuss the risk and benefits with the patients. And you are so right. We see so many patients on a daily basis. We wish they came a year ago or 2 years ago. They have tractional retinal detachments and hand motion vision. I had a patient the other day, bilateral, and it's so sad that we cannot reverse most of the damage, even if you're able to attach the retina. The vision is still very bad. So I think treating early for DR makes perfect sense. And I think, as a field, we need to start towards treating early, right? Because, you control cholesterol in cardiology so you don't have a heart attack. Of course, you have a heart attack, you get the stents or surgery, but the goal is preventative care. And we know this is a disease that's going to progress in majority of your patients, especially the moderate to severe NPDR. So, I mean, again, I offer the option to the patients, but I think patients who have good visual acuity and asymptomatic, the burden is still very high. So what are the unmet needs, Christina, in your opinion? So you have, of course, PDS will likely approve once it's back and then get submitted. We still have a while before we get there. Is there an unmet need for non-invasive treatments for DR?
Absolutely. You're spot on with that. I mean, we have a lot of unmet needs, but one of them is really more durable products that don't require either invasive treatment or as close of frequency as some of the injectables do. And of course, there's others too. Like you mentioned this earlier, but I just want to point out therapeutic endpoints and guidance, basically based on either biomarkers or other sort of imaging, is really something that we need in this field. And I know that our community is actively working on it, but we really need to know what we're treating to, right? So you can treat DR, but what do you actually treat to? And so, the question has been brought up in the past by others that, when you see this DR regression with treatment with anti-VEGF, is it really a true pathophysiological improvement, or is it merely a phenotypic change? And those are all questions that have yet to be answered. It's really why this area is so, so exciting. But I completely agree with all the points you've made. And I'll highlight two really exciting investigational candidates. And I know you're very familiar with both, but I think they're particularly exciting going back to that risk-benefit ratio we talked about. The first one is called APX 3330. This is a small molecule Ref1 inhibitor that's also being evaluated for the treatment of NPDR, just like the port delivery system that we just mentioned. But one of the most unique characteristics about it is that it's taken as an oral pill. So I'll briefly just sum up that the phase 2 Zeta-1 trial compared APX 3330 BID versus placebo BID for the treatment of patients with DRSS scores between 47 and 61. And while it did not meet the primary endpoint in that the proportion of participants with the 2 or greater step DRSS improvement was similar between the arms, there was a signal that the drug prevented 3 or greater step binocular worsening. So there's going to be an upcoming end of phase 2 meeting with the FDA to discuss phase 3 registration endpoints. But what I really like about this candidate, Arshad, is that being able to take a pill from home versus coming into the office for an injection is favorable for so many different reasons. And I'm really looking forward to seeing what the continued program shows. Any thoughts on that before I tell you about one other really interesting drug candidate?
No, absolutely. I think, that's like the holy grail, to have a pill for diabetic retinopathy where you can treat a large number of patients, right? I mean, this can be done. And I know you're very involved with AI and remote monitoring. I mean, imagine a primary care doctor, has a camera that takes a picture, the AI reads, NPDR, and then they start treatment with a pill. And then they can refer to an ophthalmologist or, retina specialist or optometrist, depending on what the pathology is. I think we're going to be able to treat a very large number of patients, because I think stabilization is what we are currently doing, right? As you said, we are not giving monthly ranibizumab or, every other month or every 3 months, aflibercept. We are extending patients who require, at least that's what I'm doing, anti-VEGF for their diabetic retinopathy, to kind of get to a point where the burden is less and they're stable, So our goal is to stop the worsening. So I think this binocular benefit is also important from a systemic drug perspective. So I think it's very exciting that this program is moving forward, and we, hopefully the end of phase meeting with FDA, and then start the pivotals hopefully next year. I know you presented this data at ASCRS meeting, Christina. How about the safety? Of course, because people are concerned about systemic medications and safety of those.
Yeah, it's a great question, especially when we're talking about an oral pill. People start getting a little hesitant because it is a little bit of a departure from what traditionally we use in ophthalmology. And it was great to see that safety overall was very, very well tolerated. And so of course, we're going to continue to monitor closely as they move on to the next phase of research. But I think that it's very promising so far. And to your point, we always do try to extend patients, right, when we have injectables, because we want to reduce that treatment burden. You don't have to do that. You don't have to do that when you have something like a pill or an eye drop, which I'll tell you about in just a second. And I think that's particularly beneficial when it comes to treating NPDR, because as you know, interruption or attrition in treatment often leads to regression of effect. We learned that from Panorama, for example, the aflibercept Q 8-week arm. In the second year, patients transitioned to a PRN protocol. And what do we see? There was still an effect, but the proportion of patients with a 2 or greater step improvement in DRSS score from baseline actually did decrease between years 1 and 2 because of that reduced frequency. And so that might be something that's avoided, right, with a pill or an eye drop. And so I just want to make sure we have enough time to tell you also about this one eye drop, OTT 166. This is a small molecular integrin inhibitor. And I think it's so cool because it's administered as an eye drop. I mean, that would be so extremely convenient. And I used to laugh when patients are like, why can't you just give me my medicine in the form of eye drop, right? Instead of an injection. And I used to laugh at that, but now this could become a reality. And OTT 166 is being studied in the phase 2 DREAM study, which is looking at eyes with DRSS scores between 47 and 61. And it actually just fully enrolled as of last month in July of 2023. So we may hear top line results as soon as Q1 of next year. I'm super excited about this. I'm crossing my fingers that we'll see some efficacy signals and good safety as well.
Oh, I think again, non-invasive treatments for a disease that does not have symptoms at times without DME, just DR by itself. I think having an oral or a topical agent is clearly beneficial. So I think, it's exciting time for patients, right? Because every time a patient comes in, they're asking for a pill or a drop before they agree to an injection, as you know. So, and there are multiple other programs, looking at pills for diabetic retinopathy. And then the last thing, obviously, Christina, is gene therapy. The altitude trial with RGX-314 suprachoroidal is also very exciting because it's a one-time gene therapy given in clinic. And the data so far is promising. Of course, we are learning about the best prophylaxis, the best dose. The trial is still ongoing. And we have seen the data cuts at different time points. But what are your thoughts on having one-time gene therapy and then stabilizing or regressing the disease? I think that's very meaningful also.
Yeah, absolutely. You and I are both big fans and hopefuls in the area of gene therapy, because when we're talking about treatment burden, there's really nothing that will beat that, right? So a one-time suprachoroidal injection, this is an AAV8-based gene therapy in RGX-314, and it encodes for a protein similar to ranibizumab. It's being looked at in the phase 2 altitude trial, as you mentioned, and it's looking at eyes with DRSS scores between 47 and 65. And it is exciting. There have been some early efficacy signals so far, even though the study hasn't been fully read out yet. But I'm really hopeful because, one of the exciting parts about this is RGX-314, as you know, is also being looked at in a subretinal approach for wet macular degeneration. And that, of course, the trade-off does require a trip to the operating room, and it's more invasive. With a suprachoroidal injection, that's something that is something that you could possibly do even outside of the operating room theoretically. And if it could reduce that treatment burden for patients in such a significant way, I think it's very appropriate and has a lot of potential for this particular disease state.
No, definitely. And, not doing a vitrectomy, also not getting cataracts in the younger diabetic eye disease population. So yeah, suprachoroidal space in clinic, and it's a pretty straightforward injection. So yeah, it's great times, and hopefully we have multiple shots on goals, and hopefully we have some better treatments. Of course, we have great treatments currently, but the burden is high, as you said. And as a field, hopefully we have better either non-invasive or more durable treatments in the future for our patients with diabetic retinopathy, which is actually a global problem, and really sad to see these patients lose vision because they don't get treated on time or because of treatment burden. So it's great to have you, Christina, here. Last two questions about yourself before we sign off this episode. So tell us, what is the career achievement that you are most proud of so far in your career?
I have to say it was the book that I co-edited with Nina Barakal a couple years ago called Women in Ophthalmology, a comprehensive guide for career and life. And that's produced by Springer. But it's a beautifully authentic collection of stories from our women colleagues in the field. And for many years, I had the idea of sort of putting together a collective repository of wisdom, experiences, advice that others had given to me that could be shared widely across the community. And this book brought that vision to life. So it's something I'm really proud of.
Great. No, I think it's an excellent book, and you and Nina did a great job helping actually everyone to learn more about the retina specialist and balancing so many things. So thank you for doing that. And last question: how do you want to be remembered once you retire?
Retire, retire. What is that, Arshad? I guess that's more of a reality for you than for me, I think. But in all seriousness, I think from a professional standpoint, I hope that I would be remembered as an ethical person with unwavering integrity, and also a caring physician who always tried to do what was best for my patients.
No, that's very nice, and I think you are actually an example of that. You have already achieved that, and by retiring, I think you are having a laugh because we have talked a lot about this, and I don't think either, as much as both of us want to retire early. I think, we are so passionate about what we do. I don't see either of us retiring ever. But I think, you have already have an amazing career so far and you're so early in your career. But I think, everybody looks up to you as an example of doing the right thing and being ethical and always keeping your patients first and training the next generation of physicians. So, Christina, thank you again for being here. And it's such a pleasure to speak with you about the latest and greatest in the management of diabetic retinopathy.
It's always a pleasure, Arshad. Thank you for having me, and thank you for all that you do for our field. You're really an inspiration for many of us.
Thank you, Christina. And thank you to all of you for listening to this episode.